Chest X-ray. This gives information about cardiac size and shape. State of pulmonary vasculature can be assessed. Then we can identify non-cardiac causes of patient symptoms, pulmonary causes. Then patient with acute heart failure, they have evidence of pulmonary hypertension, interstitial edema and or pulmonary edema. The majority of patients with chronic heart failure do not. So acute heart failure, there will be pulmonary hypertension, interstitial edema, while in chronic heart failure, usually we don't get these signs. Absence of these findings in patients with chronic heart failure reflects the increased capacity of the lymphatics to remove the interstitial and or the pulmonary fluid. So here we can see the X-ray, and we can see the pulmonary edema. Then the upper lobe vessels are prominent, the hilar vessels are enlarged, the cardiac cell hood is enlarged, and especially in settings of chronic heart failure. Then there can be septal or curly B lines. This is the enlarged view, curly B lines, septal curly B lines. Now, then assessment of LV function. This is the most useful test and for assessing the LV function, and we can assess this by 2D echo. Also we can go for MRI. Then myocardial strain rate imaging using speckle tracing can be done. Then biomarkers can be screened. Circulating levels of natriuretic peptide, they are very useful and important adjunctive tools in the diagnosis of patients with heart failure. Both the B-type natriuretic peptide and N-type terminal pro-BNP, BNP and anti-pro-BNP, both are the very useful tools in prognosticating and also diagnosing the presence of heart failure or aggravation of the failure. Then exercise testing. This is not routinely advocated, but this is useful for assessing the need for cardiac transplant in patients with advanced heart failure. Then coming to differential diagnosis. There can be various differentials for heart failure manifestations syndrome. It can be because of non-cardiac causes of pulmonary edema like acute respiratory distress syndrome, then chronic venous insufficiency, varicose veins, then also the edema and high increased fluid overload can be seen in other causes like hypoalbuminemia because of nephrotic syndrome or because of liver disease or because of protein losing enteropathy. Then there are drugs which can cause sodium retention like steroids and NSAIDs, or drugs increasing capillary permeability like the calcium channel blockers, especially amlodipine, nifedipine. They can also they can cause edema which can be mimicking heart failure. Then sometimes there is idiopathic, more commonly found in women, the signs of this peripheral fluid overload peripherally. Then chronic lymphatic obstruction also will cause edema and give a suspicion of heart failure. Now coming to the management. There are two distinct clinical scenarios, so there are two approaches. One is for acute decompensated heart failure and the other is for chronic stable heart failure. The goal of therapy are also different. In decompensated heart failure, it is priority to stabilize the patient first and improve the organ perfusion and the filling pressures. While in chronic stable heart failure, the aim is to extend the survival and the patient should lead a good quality of life and delay the disease progression. The approach therapy for patients with chronic heart failure is based on their stage classification. So according to the NYHA classification, diuretics, vasodilators and positive inotropic agents are used to improve symptoms. The neurohormonal inhibitors are used to reduce mortality and delay the disease progression. So we can see here what are the drugs we use mainly in decompensated heart failure and what we use in chronic stable heart failure. So in decompensated stages, We use the first drug of choice are diuretics, loop diuretics and thiazides, the vasodilators, the nitrates, directly acting nitrates, calcium channel blockers, if there is setting of hypertension especially, then natriuretic peptides, then positive inotropic agents are used in decompensatory states like beta adrenergic receptor agonist, phosphodiesterase inhibitors, and with calcium sensitizer action also. In chronic stable patients with heart failure, again loop diuretics and vasodilators are used. Here also we use positive inotropic agents, especially in those cases where valvular lesions are the cause for heart failure, like digitalis. Then here we use neurohormonal inhibitors, that is angiotensin converting enzyme inhibitors, ARBs, beta blocker. These all help in remodeling of the heart. Now, starting with non-pharmacological therapies, which applies to all the patients of the heart failure. So first important thing is diet. The sodium intake plays a very important role in the prevention of acute recurrent events. Sodium should be restricted. 2 to 3 gram daily is the recommended for all the patients regardless of their left ventricular ejection fraction. Further restriction to less than 2 gram daily is recommended for those patients who are already having moderate to severe heart failure. Then fluid intake, that should be less than 2 liters daily for the patients with serum sodium less than 130 milliequivalent per liter, and the patients with volume retention. So they should restrict their fluid intake. Then pre-albumin and caloric evaluation. This is recommended for patients with cardiac cachexia and unintentional weight loss. So these should be assessed and accordingly the diet should be planned. Other therapies are continuous positive airway pressure. If there is a diagnosis of sleep apnea, has been shown to improve symptoms of dyspnea. Then oxygen supplementation, sometimes it is needed in heart failure patient. If the oxygen saturation is low, we should evaluate the patient for pulmonary disease or residual pulmonary edema. Then treatment of depression also is needed in these patients with appropriate therapy. SSRIs are the drugs which are preferred for these. Routine health care, the patient should be advised to limit daily consumption of alcohol to less than 2 drinks in men and less than 1 drink in women. In patients with alcoholic cardiomyopathy, total abstinence is recommended. Pneumococcal and influenza vaccinations are also indicated. Then endocarditis prophylaxis is not recommended on routine basis just in a patient of heart failure, but in specific patients where there is particular valvular involvement or particular settings where we need to give the prophylaxis. NSAIDs are not recommended because they are associated with fluid salt retention and also acute renal failure. Then the patient should be given exercise training with the goal of 30 minutes of moderate exercise activity at least 5 times per week. Now coming to the pharmacological therapy. Angiotensin converting enzyme inhibitors, beta blockers, diuretics including the loop diuretics, thiazides, the potassium sparing diuretics, vasodilators, positive inotropic agents like digoxin, beta agonist and milrinone. All these are the drugs for managing heart failure. Coming to management of acute heart failure. Acute heart failure with pulmonary edema is a medical emergency and it should be treated urgently so as to prevent the mortality. The patient should initially be kept rested with continuous monitoring of cardiac rhythm, the blood pressure and pulse oximetry. Intravenous opiates can be of value in distressed patient, but they must be used sparingly because they may cause respiratory depression and also exacerbation of hypoxemia and hypercapnia. Hallmark of therapy for acute heart failure is intravenous loop diuretics. If the patient exhibits signs of normal cardiac output, nitrates or neseritide could be used to assist with vasodilatation. If there is low cardiac output and end organ damage, inotropic agents could be used. However, There is no evidence that these give long-term benefit. And in fact, there can be sometimes more harm and the mortality can increase because of the use of this. Then reduction of hospitalization for acute heart failure is very important to reduce the mortality and morbidity. So, there are a few maneuvers with their effects, like the patient, as the patient is, keep the patients in sitting position, that will reduce the preload. Then high flow oxygen will correct hypoxia. Continuous positive airway pressure support by tight fitting mask, this will reduce preload and pulmonary capillary hydraulic gradient. Nitrites, they will reduce preload as well as upload. Loop diuretics, they combat the fluid overload. So these are the drugs with their action, maneuvers and their action. Now coming to management of chronic heart failure. The aim of treatment in chronic heart failure are to improve cardiac function by increasing contractility, optimizing preload or decreasing the afterload, and controlling cardiac rate and rhythm.